is one of the few countries that has passed legislation and that has opened up the landscape, the transplant space to include disease donation. In the Caribbean, diabetes is an issue. People with diabetes need dialysis or transplant.
Good afternoon. We have a patient coming to the emergency ward.
You lose all of this time taking dialysis.
When I was on dialysis, I used to feel a lot of pains, tired, short of breath. After kidney transplant, for me, life has been going great.
Good morning, guys. I am Nurse Briggs, and we are the Kidney Transplant and Vascular Unit.
I was in my third year of medical school. I did a random blood test just to check up, and I noticed that my blood values were a bit off. I was diagnosed with chronic kidney disease. It was a bit of a shock. At around 2019, 2020, I needed to start dialysis.
This here is a revolutionary piece of legislation, and it will take Guyana into the future. This is about 21st century medicine. Thank you, Mr. Speaker.
We had our first kidney transplant around 2011, but we never had a law. If we are going to transplant organs, then it must be done in accordance to worldwide standards we have incorporated into our laws. The law is already catering for technologies that are now being discovered. We have set up an independent body that would make the policies and regulations.
I am Dr. Shanti Singh Anthony, chair of the Human Organ and Tissue Transplant Agency. In the Caribbean, chronic diseases, and particularly diabetes, is an issue. Approximately, I think, 1/3 of people with diabetes will progress to end-stage renal disease and will need dialysis or transplant. The Act of 2022, it opens up the landscape, the transplant landscape. We're working on kidney. Living transplantation is what we currently do, where someone comes forward with a relative or somebody to donate. The idea is that we will scale up our transplant program to move beyond kidney. With transplant, productivity is better, quality of life is improved, life expectancy is longer. For the individual and for the economy and for the country, there's significant benefits.
Over the past 9 years, we have done over 55 living donor transplants, approximately 1 transplant per month. So at the present, we restrict ourselves to kidney transplant because that is one of the easiest transplants. We stick to what our capacity can handle at this time at the hospital. To achieve more transplant, there will have to be an implementation of more staffing, more technology, and more screening method in terms of advancing and expanding the program.
There is a huge demand for transplant in Ghana. If you just visit our nephrology clinic, you'll find that there are lots of patients that are on their way onto dialysis, or there are patients that are already on dialysis.
We have over 300 patients on hemodialysis at the moment.
Someone with end-stage kidney disease who then moves on to dialysis, there are consequences, like there's significant decrease in the quality of life of that person. There's loss of productivity. And so with transplant, it is decreased.
In this country, it costs for the patient to access hemodialysis in a private dialysis center. That is a significant burden to the patient. If we move towards cadaveric transplant, that will not only take the burden of the patient, the family, but will take the burden of the healthcare system.
Not having to do dialysis makes a huge difference in terms of your quality of life. It's also very draining, it's very tiring, and things that you were used to doing are sometimes more difficult. It's also something that is mentally draining and can be debilitating.
It will move a patient from being a dependent patient, sick on hemodialysis, and make him independent patient that can work, contribute to his family and to society.
We want to make sure that the human resource that we have around the transplant program, that capacity is built so that we can scale up transplant. One of the requirements is that the hospital must have a transplant coordinator. And so Georgetown Hospital has identified that person, that we want to make sure that we can onboard kidney disease donation.
The deceased donor transplant will open so many doors and access to so many other people, because currently we do live donor transplants and we have patients that have people that are willing to donate, but they may not be eligible, either for their personal health reasons or they're not a match. It would increase the access of this life-saving surgery for so many others. And COVID has created a lot of kidney disease.
Every time we needed to do a transplant, we had to send the test to be done in Miami. It would cost us probably about $3,000 per patient.
We've done an assessment and we've certified GPHC as a transplant center for disease donation as well as living.
So we need to look at doing renal biopsy and have a renal pathologist to read those slides to be able to tell us whether we have an rejection or any other pathology within the transplanted kidneys.
The equipment to be able to do HLA testing, which is a key test for transplant, has just arrived in the country. And so we're beginning to put that lab together. By mid of next year, if not earlier, we will have the lab up and running to be able to support the transplant program. We're doing roughly 10 per year of living, but we're now starting disease. And so a conservative estimate that we have is about an additional 2 to 3 per month of disease donation. That will bring us to about 48 per year. We want to make sure that living donation for kidney is going well in the near future, and then we'll move on to others. To be able to set up a transplant program, it requires a lot of resources, financial as well as human.
We need to be able to do drug levels, such as tacrolimus, because the benefit of that drug is more significant at that specific level in the body. We need to be able to do cross-matching, where you match the donor and the recipient in terms of whether the recipient has antibody that will fight against the donor kidney.
Building the laboratory component, for example, for the transplant program, will mean that the health sector will have access to sophisticated additional testing.
So, after transplant, most patients express their gratitude. Most of them are back at work. They're providing for their family. Recently, we have done the smallest child in the Caribbean, approximately 17 kilograms, and we have done that transplant successfully. She's actually outside.
I'm here with my daughter, who is a transplant patient, and I'm the kidney donor. Our pediatrician found in her abdomen that the liver was swollen, so he made the diagnosis of the condition polycystic kidneys, which basically degenerates with time and ultimately leads to kidney failure and transplant. My daughter, Angelica, she was 6 months old at the time, and we were advised to seek the assistance of the public hospital. We visited a nephrologist, and he advised that we will need a transplant very soon. We reach a point where we have to do the final cross-match test. That is to determine that the kidney is a perfect match or compatible that they can actually do the transplant. Luckily for us, the kidney matched. All arrangements were made and everything was done with the transplant team here, along with the consultation from Professor Yilmaz. The ministry also supported us in terms of the finances because the cross-match test is quite expensive and it's subsidized by the government. During that period, there's a lot going through our minds because it's the first kind of surgery to be done in this facility, and I think probably in the Caribbean for somebody that small. It's our only child. We were assured by the team that things will work out. They have the best possible solution. And I remember coming out of surgery, I was shivering. And the first thing the team asked him, "Is my daughter okay?" And he said yes. We came out from theater and went straight to the recovery unit. So she's going to be in the school. The school is a pretty good school. It's privately owned.
Academy of Excellence, doing studies.
But her mom is going to be there with her to provide the support using the facilities. It needs to be clean and sanitized before because she's on immunosuppression drug. She's going to be in a class, but it's going to be an environment that she can work in because with her restrictions, we have to create a little bubble, so to speak, for her to operate in. So she will be in the class, but not interacting 100%. I don't want to limit her. I want her to develop, and part of her development will be the interaction to develop her social skills, and we cannot do that with her being at home all the time. For her school, we try to give her a normal life as possible. The intention of the transplant was to see how best we can get to that point.
Yeah.
I had my kidney transplant in 2021. My donor was biologically my cousin, but she's more my sister. Her name is Yanis, and she offered, and we were a match. So we were good to go. And in a few weeks, I was out of hospital. This was in 2021. This was in the height of the pandemic. I had to stay at home a lot and stay indoors and be very careful because you can imagine getting COVID after just receiving a kidney transplant could be quite detrimental to your health. Life has gone back to normal for the most part. I just have a few restrictions that I need to be mindful of in terms of the environment, infection, cleanliness, staying away from people who are obviously sick. I was even able to complete my master's degree. As soon as I had finished my surgery, I was able to get one of the gold scholarships, and while I was awaiting the pandemic to be over, I was at home studying. I go to work every day, I come home, I go out, I can travel, I can study, I can work, I can have a family if I so choose to.
Guyana really is taking the lead on this for the Caribbean region.
GPHC, Dr. Kishore and his team, thank you very much.